Right, we're going to switch gear a little bit. We talked a lot about rectal cancer. This is also a real case that is happening to me as we speak. This is a 58-year-old gentleman diagnosed with early rectal cancer in the mid to upper rectum. This is, again, reviewing the records. A lot of these measurements were not done with rigid proctor. He had a CT of the abdomen and pelvis, not chest, which was negative. His CEA was normal. He had an open low anterior resection, was found to have a T3 and 0.24 negative lymph nodes. Unfortunately, he did not receive neoadjuvant because he was thought to have early cancer, and did not receive adjuvant because he was admitted to King County Correctional Facility for a minor offense, nothing major. But nonetheless, he spent some time in jail, and therefore we missed the window of opportunity to see him back. The referring physician missed the opportunity to see him back and to recommend any additional adjuvant therapy as well as follow-up. Eventually was released from jail. This is a CT scan from before the operation, the original CT. As you can see, this was the only staging modality utilized. This doesn't look like a very early lesion to me. Obviously, I didn't have the opportunity to examine him, and as we heard from many today, the best approach to recurrent rectal cancer is at the initial operation. It's to be the right plane, do the right operation at the right time. Well, since we can't change what has happened in the past, he eventually was released from jail and went back to the original physician with some lower GI bleeding and tenesmus, and flexus sigmoidoscopy showed that it was a recurrence at the anastomosis, biopsy proven. I don't have pictures of that, of the endoscopy, of the flexus sigmoidoscopy, and it was sent to us for management. Open to the panel here. What is your approach? You see this day in, day out, I'm sure, this kind of referral. What is your diagnostic approach when you get a patient like that?
What level is the anastomosis exactly?
The anastomosis was actually, the tumor was probably higher than 10 centimeters because I can barely feel it with my finger.
But you say you can feel it?
I barely, and this is a very thin man.
Okay, so probably maybe 8 centimeters, something like this.
Yep.
Okay, on flex. So, yeah, I mean, you've got to do a staging of the pelvis with MRI and see what's going on there, and then probably a PET CT to stage everything else. Anyway, for starters, you already did your endoscopy and your biopsy.
Yep. Any?
I would try to get outside op notes and the pathology reports, see what it is described peeling the rectum off some other structure and what the resection margins were. The operative report was not, didn't show 6 hours or complicated dissection. The number of nodes was reported there. There was no description of the completeness of mesorectal dissection, which is unfortunately is a common problem, as we know. It's hard to get the pathologists to report on that. The margins, the surgeon didn't comment on that. In the pathology report, there were 2 centimeter distal margins on the fixed specimen. So,
yeah, I mean, it's also interesting. I think it's imperative to get the pathology report because it's also always interesting to see what the size of the specimen is and you know, whether or not this was a little segmental resection or was a real cancer operation. And you want to know the distal margin, obviously, what she said. And then you're going to stage the entire, you're going to recolonoscope the patient, make sure there's nothing else. You're not, I wouldn't take it for granted that the patient's colon was properly evaluated originally. You're going to, you know, do a PET scan and a CAT scan and look for distant disease.
You know, an interesting point is not only should the slides be reviewed, but it may be worth getting the tissue blocks on a case like this because despite the pathology report saying that there were negative margins and the rest of it, it may not be the case. And we've seen that more than once where the pathology report talks about a complete mesorectum and the margins are fine and everything else. And then our pathologist will look at the specimen and actually find mesorectal implants or find tumor within 1 millimeter of the radial margin, you know, on recutting blocks. So on a recurrence, it is sometimes worth just like we look at the op note, you know, but you can't go back and look at the video necessarily. Right. You can get the block and make sure it's appropriately staged. Maybe think, you know, lymphovascular invasion, they miscalled that. I mean, there may be something there that's worth knowing.
I think another thing just worth mentioning is it's often helpful when you're looking at things endoscopically to have the sense, is this something that's recurring mucosally that's growing outwards, or is this something that was in the mesorectum that's growing from the outside in? And oftentimes you can get a sense from that not only by the images, but by the endoscopic view of things.
So let me ask you a question. So when you get those blocks and they see something, is it going to make a difference in what you're going to do next? And can you explain to the audience what the decision tree might be for you?
Well, it might, because you're talking about...
As long as it's resectable, it's a central recurrence.
Well, if it's a central recurrence and you know that the margins were probably involved, I'd have a very low threshold to give, you know, pre-op neoadjuvant. Whereas if this thing is barely reachable by a finger, I'm not trying necessarily would automatically give everybody chemo-RT if this is up at, you know, intraperitoneal, for example. I don't know where this anastomosis is, but, you know, if this tumor was at 10 and immobilized, maybe the anastomosis is still at 10 or 11. I don't know that I'd necessarily just automatically give everybody chemo-RT. I'd have a much lower threshold for doing it in combination with what the MRI shows if I know the margins are positive.
Yeah, you guys have not seen the MRI, so perhaps we should show that, but
I think it's highly unlikely that for a cancer, for an anastomosis in the mid-rectum, the treatment for this is pretty straightforward. You know, there's a radiation-naive patient, they have a recurrence. You have to figure it's a technical issue. It's happened within a year of the operation. You're going to figure that there was cancer in the field, you're going to radiate the pelvis. From a theoretic standpoint, I agree with you. You're not going to radiate everyone, but I think in this type of situation, you know kind of what happened.
Was the primary surgery done laparoscopically, open, or robotically?
Open.
Open?
Yes.
So there's no video available?
No video available.
No, but you're also going to have a higher incidence of small bowel injury and stuff because it was done open. There's more adhesions, which again raises the point of just being sure you want to give neoadjuvant. And I agree, you probably do in most cases, but not necessarily in everyone. Here's a guy may disappear and be incarcerated again in the midst of his chemo-RT, and then doesn't get surgery at all. So maybe this is a guy you just want to do the surgery before he goes and gets arrested again.
That's a tough sentence.
Huh?
That's a tough sentence.
Yeah.
So the point of luminal recurrence versus mesenteric recurrence, I think, is important in making that decision as well. I don't recall who brought it up.
And I actually, someone had texted in this question before, which is a little bit off, but people had asked about the possibilities of laparoscopic IORT. And I know this isn't really for this case, but I wanted to ask you guys, because it was a question from the audience. Has anyone done any brachytherapy or anything like that with laparoscopic surgery?
So there's not a device specifically made for laparoscopic IORT, but there's almost always a defect through which the specimen came out. For example, if we're doing the APR, sometimes you can put the brachytherapy catheters in through the defect perineally and still administer that way. It just depends on the anatomy and the case.
But usually the radiation therapists and the physicists, they want nothing to do with that. They want to be able to get in there and move everything. I think the short answer would be no.
Yeah, I typically would use a fan and steel for a non-APR, and in a man like this, there is a possibility of, I think, fitting a smaller cone, depending on what we find. I haven't operated on him yet, so I can't answer the question of where the anastomosis is yet. Workup we discussed. This is the study before, and this is a PET scan. We repeated there is uptake at the level of the anastomosis. It's not particularly impressive. And the MRI shows, doesn't project too well, but there are a couple of arrows there. They show a couple of lymph nodes. No invading bony structures, nothing that would contraindicate a radical resection, but something clearly outside of the mesorectum. So it appears to me, to answer that question, that the luminal component is not as predominant as the mesorectal component, as we previously discussed. And I don't want to answer my next question. So it looks like there is mesorectal disease. Looks like there is a luminal component. Looks like those nodes are a little bit off, and I'm sorry it doesn't project better, a little bit outside of the typical field of resection. So does that change anything in the discussion that we have had so far?
I think you're going to give neoadjuvant to this guy, and then you're going to be able to presumably resect an anastomose, most likely.
Yes, I think that's the only way to do it.
In the original CAT scan you showed, didn't it show that it was butting up against the bladder?
It looked
So
that
would
way.
worry me, and I would tell him that there's a good chance he might lose his bladder in this too. I would radiate him first, and I'd have my favorite urologist in there ready to take his bladder out. I mean, it's drastic, but it looks to me like could have been better surgery the first time, and you have to, it probably should have happened the first time.
So would you do a cystoscopy, Tracy?
No, I wouldn't cut through any of these fibrotic adhesions, and if it doesn't come up and you can't tell, you're trying to save this guy's life, and I would take his bladder out.
Well, I would have this guy cystoed on that CAT scan before he started therapy for documentation's sake in a case like in a patient like this for sure. And then depending on what they saw, I mean, I think that's an excellent point. You're not going to cut across fibrosis, but if this is higher up, you can take off the dome of the bladder, but if it's involving the trigone, you're stuck doing a pelvic extent.
It didn't look like that on the first CT, I don't think, but that's a good point. And, if the cysto doesn't show anything, it still doesn't mean you're not going to
No,
do
it doesn't
that.
mean anything. I'm just saying, particularly in a recurrence and a guy who's coming out of jail, I would like to document everything.
True.
This is exactly my point of reviewing, because you might find on your slides that the anterior margin was in fact involved, and it really pretty much gives you an answer.
I think to go back to the margin point, this patient had a tumor reported initially at 10 centimeters and had a 2 centimeter distal margin. And that technically is not adequate. I mean, 2 centimeters is adequate for a very low rectal, not 1 at 10. So this is not actually
so what was adequate
surprising.
about everything in the whole scenario?
Nothing.
Okay.
So, I mean, this is not surprising, given.
Right.
And I agree with reviewing the records and everything else, and perhaps for prolapse surgery it's a little different, but my experience has been when reviewing operative reports of rectal cancer surgery, they all say the same thing. And we have done this for credentialing for many prospective studies, and we have read many operative reports, and they all say the same thing. Nobody says, I went in down there with my hand and dug that out. I did. Nobody says the cancer perforated. Occasionally may say that. Nobody said, I coned in, and the specimen comes out, is always perfect. Now, then you get the pictures for credentialing, and you see pieces of meat that you cannot recognize. So I don't disagree that you need to review those records, but I don't think those records help you that much. I also agree that I was concerned about the bladder, but I'm afraid that that plane has been already violated. Now, I don't see anything on repeat studies. So I don't think the lesion is adherent to the dome of the bladder. I think I'll find a totally separate plane. Now, the only way to know for a fact would be to do a pelvic exenteration in a guy that is not reliable. I'm not sure about margins, and I'll show you some post-treatment images here. To do an exenteration without proof of bladder involvement, I don't know. I haven't really thought about that. This is the post-treatment CT scan. As you can see, the arrows are still there. Those nodes are still there, definitely smaller. You can see that I'm concerned about the posterior margin on the coccyx. There is some haziness in the back. There is no way, again, to know if this is necrotic tissue or there is invasion of the coccyx. The plan is to take the distal sacrum and coccyx in this specific case. I haven't made plan to take the bladder because I'm afraid that that plane has been violated. I don't see a disc of dome that I can take, as John was saying, and the only way to know for a fact would be to do an exenteration. And considering all the other factors that Nancy was mentioning at the beginning, patient's-related factor, I think is pushing it a little too much. And I'm told we are done. This has been a great panel. I believe the room is full, and a great discussion, and I want to thank all the presenters for their talks and expertise. Thank you very much.